Without question, every major discovery we've had in cancer has come on the shoulders of a clinical trial. As oncologists, it's a very exciting time because we have so many things in our pocket, if you will, to treat patients with. The patient benefit is they're getting something new and different that we think might work better than our current strategy. And we're studying that to answer that question. Is this the same or is this better than what we're currently doing? Essentially, one concern or one question is, am I really getting something? I don't want to get, quote unquote, a sugar pill or this, that, and the other. And fortunately, most of our cancer trials is looking at regimen A versus regimen B. We do not have trials with patients who actively have cancer that we're not giving them really any therapeutic regimen for. It's so important to realize that patients are actually receiving treatment. We're just trying to determine which regimen is better for that patient, that disease. And so I do think the paradigm has shifted some, and I think because of that, patients are getting benefit because they're getting investigational agents that hold, at the very least, a promise of miraculous, responses early on in the course of their cancer process. And going back to our first day of medical school, first do no harm.
Absolutely.
And that is that's so important, in particular with clinical trials, because it's the patients themselves that hold the greatest benefit when we hit those singles and doubles and hopefully home runs in our trials.
Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Hey everybody, welcome back to our show. We are super excited to have Dr. Rod Rocconi in the studio today. Dr. Rocconi is the interim Cancer Center Director at the Mitchell Cancer Institute and also serves as Associate Director of Clinical Trials. Rod and I have been friends for a very long time. He has been doing clinical trials since he finished his GYN Oncology Fellowship at UAB in 2007 and is a nationally recognized speaker and expert in GYN oncology clinical trials. So you're going to hear more about a particularly interesting trial as part of the innovation segment. But for now, we're going to get to talking about what are clinical trials, how are they different from regular chemotherapy, and why you want to know more about this. Rod, welcome to the studio.
JYP, thank you so much for having me. I really enjoy this podcast, and thanks to all the listeners out there. Hopefully we'll teach you guys some things about clinical trials.
So first, what is a clinical trial?
Yeah, so in essence, we classify any type of patient research into two categories. So one of which is what we call clinical research. That's where a patient is asked to potentially give specimens. That could be a blood draw, it could be a urine sample, something like that, for research purposes. So you can look at certain proteins and things within those, specimens to make some discoveries in regards to helping with cancer care, in the future. The second is clinical trials, where actually, in addition to maybe even getting specimens, we're actually doing something therapeutic. We're doing an intervention, something that we're giving a patient a little bit extra. Sometimes that could be a medication, a new medication. Sometimes that could be a surgical trial to where we're trying a new technique or a new instrument. So a lot of different ways, but that real breakdown between research and trials is we're giving something a little bit extra for that patient.
Yeah, and I always tell patients a trial doesn't always mean something new. It could be an older medication that we are trying in a new way. The best example being the metformin trial. It's an older diabetic medication that actually we found some patients who took it did better. And so now we're putting it in with chemotherapy.
That's exactly right. What was old is now new again, and kind of repurposing certain agents as we learn more and more is a new strategy that we're employing quite a bit.
Yep. Other thing I talk to patients about is at Mitchell Cancer Institute and other academic cancer centers, you may be invited to participate in a clinical trial that's actually not chemo. It might be about nausea medicine or sleep medicine or something to help you feel better after chemotherapy.
Yeah, that's exactly right. And so it doesn't always have to be about cancer care. I think as Jennifer, you and I, as we take care of our cancer patients, can be some very complex issues. Patients can be actually without cancer at that current time, but have side effects from either the cancer itself or side effects from the treatment they received. And there are, interventions and things we can do to help those patients with that. And that can also encompass the clinical trials. Sometimes it's, behavioral supportive care, that we're providing to the patients. And obviously it's very important, near and dear to my heart with clinical trials. Without question, every major discovery we've had in cancer has come on the shoulders of a clinical trial. And that's, in my opinion, a testament to the patients, who are actually participating in it. And we'll get to it, I guess, a little bit later. But as I'm talking to patients about why to enter a trial, one of the reasons is a little bit of it's paying it forward. We have a question we want to answer, with the trial. And hopefully we're making things better so that next patient, for us, GYN cancer docs, that next woman who has the same situation that patient has, the question's already been answered, and we're improving that care for other people down the road, and it's so important.
Yeah. Let's get to that. Why do we encourage patients to participate in cancer trials for their own benefit?
In addition to paying it forward, I think some of the patient's own benefits, and I'll talk in the framework of a therapy that is driven to get rid of cancer, because that's the majority of what we do. And so I think the patient benefit is they're getting something new and different that we think might work better than our current strategy. And we're studying that to answer that question. Is this the same or is this better than what we're currently doing? Another benefit we see with patients is that we believe, and studies have shown this, that if you're on a clinical trial, that patients' survival and their cancer outcomes are actually better. And I think part of that might be that we follow those patients closely. We see them more frequently. There's a lot of visits. They see a lot of different people, the physician, our nurse practitioner, our clinical trial staff, and nurse coordinators that help with clinical trials. So there's a lot of benefit, I think, that the patient gets, not only with their cancer care, but just their generalized care.
Absolutely. And I feel like they receive that benefit whether they're receiving the experimental medication or not. One of the things you and I talked about was explaining to folks how clinical trials are run in cancer specifically and kind of how that's different from in other disease types. I think people worry that they may not be getting standard of care if they're on a trial.
Essentially, one concern or one question is, am I really getting something? I don't want to get, quote unquote, a sugar pill or this, that, and the other. And fortunately, most of our cancer trials is looking at regimen A versus regimen B. And then if there's something new added to that, it could be regimen A with the new agent versus regimen B, which, is without that agent. And so we do not have trials with patients who actively have cancer that we're not giving them really any therapeutic regimen for. And that's so important. And it might seem like a common sense thing, but it's so important to realize that patients are actually receiving treatment. We're just trying to determine which regimen is better for that patient, that disease.
Yes. I always describe it, for patients. So a lot of times it's standard of care versus standard of care plus something extra that we hope will give additional benefit.
That's right.
But the reason that we try it in a clinical trial is because there is that possibility that there's no benefit. And we don't want to put more people through additional medication or additional side effects if there's no benefit. That's
right. And JYP, I'm a little bit of a less is more kind of guy. And I think that in addition to that and looking, does it work better, is anytime you have any medication, there's always a potential of side effects. That's something that all of us as cancer providers are very aware of. And with the clinical trials, we can monitor that so carefully that we can determine that, hey, it might be the same or a little bit better, but it's so toxic that it's not worth doing. And that's another very important part of, clinical trials and our monitoring and why we're following patients so closely.
Can you explain to folks, when we talk about what are clinical trials, as trialists, we think of things in phases. Can you explain to folks kind of what those are and how they differ in terms of the patient risk and the patient benefit?
The main phases, and there's a lot of nuance with this, but in general terms, phase one is that we're trying something first time in a patient. And what we're really trying to determine is at what dose can we give without toxicity. And so we start off at a very low dose and incrementally kind of work that up until a patient starts having side effects. And we realize, okay, that's too much. Now we need to back down. So that the phase one is really trying to establish what is the dose that we need to use. The second phase of a study, so once that's been determined, is then you go on to, say, for example, ovarian cancer. And you take that dose and then you give it to a group of patients, monitor their side effects and monitor their response. And so that's what we're really looking in phase two is, does it work? Phase 3 is a much larger study. That's when it takes, as you mentioned previously, here's the standard of care. This is the best regimen we have for a certain patient, for, again, ovarian cancer. And we compare that standard of care versus standard of care plus something else. And so that's the general phases as we work through the process. The good thing about that is it seems laborious. It's a long process at times. It can take years from that phase 1 all the way through. But that's purposeful, because we don't want to go too fast too soon. We want to make sure we're being very aware of potential side effects, potential problems, and going back to our first day of medical school, first do no harm.
Absolutely.
And that is that's so important, in particular with clinical trials.
The other thing I try and make sure that patients understand is the drug experiences all 3 phases of the clinical trial, but the patient does not.
That's correct.
So when a patient is experiencing a clinical trial, they are experiencing it almost in the reverse order. When a patient has a cancer that is very curable, the lowest they would be is a phase 3 trial where we really are going to make sure they always get the standard of care arm. In a patient with more advanced cancer, we may recommend a phase 2 trial where there is an opportunity that their cancer matches with a particular treatment that we really feel like they individually might have a benefit from. And for patients with very advanced cancer, sometimes those landmark things that you've heard about, patients who maybe didn't have hope, who then participated in a clinical trial and experienced really a miraculous response to a new medication. How do you talk to patients about which types of trials they should participate in when?
In general terms, that's true, in regards to the reverse order of phases. But one kind of misconception or one thought, like a common question I think we get from certain patients is, well, I thought clinical trials was just for patients who, quote, we have nothing left to give. And that's not true. And although I do agree it goes somewhat in reverse order, we do have phase 1 trials for patients with, still with that curative intent with the first diagnosis. Again, those studies are, standard of care plus something else. And so I do think the paradigm has shifted some. And I think because of that, patients are getting benefit because they're getting investigational agents that hold, at the very least, a promise of miraculous, responses early on in the course of their cancer process.
Hey, Rod, this is a great place for us to take a break for our innovation segment. Why don't you tell our listeners what you've been working on?
Yes, I would love to. Not only am I the interim director at the Mitchell Cancer Institute, but I'm also a GYN oncologist, taking care of patients. And some of the research that we're working on right now is involved in improving patient outcomes and survivals. Essentially, we had a phase 1 trial, so first in humans, where we were using a vaccine that was directed towards a patient's tumor. And so generally, that's called targeted therapy. What was unique about this, we're one of probably only 4 places in the country that are doing this on solid tumors. We had ovarian cancer patients where the standard of care was to remove the cancer. Once we removed it, we actually created a vaccine that would attack or attach to that cancer specifically. And with it, it was almost like a Trojan horse phenomenon as we piggybacked an immune booster, so utilizing a patient's own immune system to help attack, their own cancer in a very, very targeted way. This technology is only good per patient. So for Mrs. Jones, for example, that had surgery, this vaccine would only be good for Mrs. Jones in her treatment. What we saw that I think is remarkable for these patients with recurrent ovarian cancer is that if a patient had a robust immune response, is that they had an increase in achieving a 3-year survival from 70% compared to 25% of patients. So significant improvement. Additionally, from a survival, the patients who had a good immune response with this vaccine, these patients lived 4 times longer. So we're currently working here in Mobile with another set of studies to evaluate this further, but have been extremely pleased with our results thus far. And I think it's an example of the type of research that's done at an academic, research-driven cancer institute like the Mitchell Cancer Institute.
That's amazing. I so enjoy hearing about the research we have right here in Mobile. But now let's get back to our conversation. I did want to spend a minute talking about what's different in clinical trials now than maybe 10 or 15 years ago. When GYN oncology in particular, we have seen a compression of that time from drug being studied to in a patient's hand. But at the same time, we've seen a significant fall off in trials and trial participation.
There's a lot of moving parts with that. As oncologists, it's a very exciting time because we have so many things, in our pocket, if you will, to treat patients with. 10, 15 years ago and beyond, and I'm not going to date ourselves, JYP, but we've seen that spectrum where we really only had a limited handful of options for certain patients. As the pipeline, if you will, from through the phases have sped up, also, giving credit where credit's due, the FDA has really had a fundamental change a few years ago in their approval process. There was a period of time where 18-month period of time where there were more new agents for ovarian cancer than the previous 18 years. It's
incredible.
It's staggering, and who benefits from that is our patients, because there are more clinical trials available because of that, and there's more agents, that these patients are able to go through that. The second part that you mentioned about clinical trial accrual is so important, and obviously one of, my passions for research is working on, equity in cancer care. Our patient population here in South Alabama is made up of 2 to 3 times the African American population of national average. So we're greater than national average, and so that historically, calling it for what it is, there's been some tragedies and some real how not to do research has been shown right here in Alabama at Tuskegee. And so that trust, has been broken down. It's up to us to build that trust back up with those patients.
Absolutely.
And I'm proud of the fact that our cancer center, I think all of our efforts in building that trust is, we have a 30 to 40% rate of African Americans entering onto our clinical trial portfolio, which I think is outstanding. But, comparatively, minority patients make up less than 2% of all clinical trials nationwide. And so overall, the numbers are dropping, but in order to really kind of make gains in cancer care, we've got to study it, and we've got to really focus on the patients that the clinical trials have dropped the most. Women is one,
Absolutely.
Special group, if you will. I'm not saying that women are not special by that. Let me clarify. But
for years, folks thought that they could study drugs in men, and then whatever they learned about that would just naturally apply to the rest of the nation. And we found that that's simply not true, that there's different, the drugs break down in the bloodstream of women in a different rate. There are different side effects experienced from women from men. And I think now we're seeing the same can be true for minority populations, that we want to make sure that there are enough patients representing every diverse part of this United States and beyond, that we can account for those differences in our own DNA, in our immune system's response to both the drug and the cancer, and how we're going to benefit from especially these immune drugs, but all clinical trials may be different.
One example I have of that, of how important it is, there was a specific inhibitor called IDO. We won't get into all the specifics, but it's part of immunotherapy for cancer for our listeners out there. And it was a failed agent. It was going through the pipeline. They tested it in ovarian cancer and found that the response rate was too low and was not an improvement. Some of the work that we've done, and Jennifer, you've worked on this project with us, is we looked at patients with ovarian cancer, African-American patients, and saw that IDO and that pathway was significantly overexpressed, meaning that these patients likely would respond and respond well and better than probably their Caucasian counterparts. The problem, when I went back and looked at the 2 studies in ovarian cancer, there was not a single African-American patient in those 2 studies that on the failed agent. And so the point of that is that we're studying the wrong population.
Right.
What we needed is 2 trials of African-American patients with ovarian cancer, and it might be a different tune. And so that's a perfect example of why we need to cast a wide net. We need to study and evaluate this in patients, because it's the patients themselves that hold the greatest benefit when we hit those singles and doubles and hopefully home runs in our clinical trials.
Absolutely. We need to switch gears a little bit to talk about how a patient enrolls in a clinical trial. Walk us through what that's like in your practice.
Like most academic cancer centers, we're built on a foundation of research and clinical research and clinical trials is that. Our mechanism is that, we'll see a patient. So maybe a patient sent to us with a new cancer, a patient sent to us with a recurrent cancer. or sometimes they're referred specifically for a potential of a clinical trial that we have open, because those trials are published, on the website and nationally, so people can look for that. So once we see that patient, we do our typical workup and talk to the patient about the options of treatment. And as I tell patients, there's multiple ways to do this. There's chemotherapy, there's investigational therapy, and there's clinical trials. And so our routine, once we see the patient, talk to that, we always present at a tumor conference, as we call it. And essentially, all that is a bunch of docs sitting around a room that we all take care of cancer. Each of us have different, experiences, different training, and we put our heads together and look at images. We look at pathology and determine, what might be the best, collectively putting our heads together, what's the best treatment for that patient. Part of that conversation, what is so vital in that conversation, is that we always ask the question, is this patient a candidate for a clinical trial?
Yeah. Our listeners have heard about tumor boards when we've talked about how you get diagnosed and how we move into that next step. So I think this is an important component for them to hear as part of an academic medical center.
Absolutely. And then from that moment, say a patient is a candidate for a clinical trial, we then contact the patient and speak to them, directly about the clinical trial. Here's what's involved with it, what agent's going to be given. Here's the pluses and minuses of this study, potential side effects of this trial, and then do a more thorough, screening, looking at blood work, maybe getting another CAT scan to make sure that patient fits the eligibility for a trial.
Can you talk to us a little bit about what that looks like? Is it only for patients who are the absolute youngest, healthiest patients, or is there some leeway there?
Definitely some leeway. I mean, we mentioned a little bit earlier about special populations. I think we mentioned gender, we mentioned race. Age is another population that the older, more mature patients, I hate using the word elderly, but the more mature patients, the way they process agents and drugs and their own body makeup is different. And so it's important. And so there are some things that from a patient standpoint that they might not be a candidate for, a trial. Mostly that has to do with other, health concerns. If a patient has liver disease or has lung disease or kidney disease, then that might eliminate them from the trial. It's not that we don't want to help that patient. It's just that we know that we need those things to be healthy for them in order to not have the side effects that could go along with it.
And to really be as safe as possible.
That's
given
right.
I always talk to patients about, it's not that we don't think you might be a candidate for this medication in the future, but because there's increased risk to you and the benefit is not clearly defined, that it may not be worth the risk.
That's exactly right. And everything I think we do in medicine has that risk-benefit ratio, particularly clinical trials. And along those lines, what's important when we're talking to our patients about, clinical trials, our goal really is to do what we think is in the best interest of the patient. Sometimes that's a clinical trial. Sometimes it's not. We're real proponents and fans of clinical trial because we think it's best for our patients in general, not necessarily every patient.
Absolutely.
And so I've had patients where I said, look, you're eligible for this study. I know you could tolerate this study. However, I think this is a better option for you. And it might be standard chemotherapy. It might be standard immunotherapy. Again, at the root of who we are, it's making sure whatever we do is best for our patients.
Absolutely. Do you ever have patients who say, gosh, Dr. Rocconi, you're such a big fan of clinical trials. I want to get on a trial. That they're asking to be maybe referred for a trial or to seek out those opportunities.
Yeah, absolutely. And we welcome those conversations. Personally, I try when I see a patient for the first time, that's someone that I'm likely going to be seeing and treating for years. And we might have multiple treatment plans over that time frame. I always bring up the possibility of a clinical trial. It might not be now, but it might be later, and it's always something to consider. Additionally, we consider cancer and cancer care as we share a lot of patients with a lot of our colleagues from across the country. And it might be a trial, but it might not be a trial here. There might be one of our colleagues someplace else that a patient can travel for that we think that's the best option for them and they can go there, or vice versa. Mm-hmm. We've gotten referrals from other academic centers because we had a trial that particular physician felt that it was best for their patient to come and travel to us to be a part of that trial.
I think we've worked our way through most of the common questions. So I'm just going to ask you, is there anything else you feel like patient or a future patient should know before they embark on this journey that a physician is asking them if they'd like to participate in a clinical trial?
Yeah, for our patients, be in charge of your own health care in some regards. Be an advocate for yourself. There's nothing that I enjoy more than a patient coming to me with, hey, this is something I read about, I saw, someone suggested this. I know Googling everything can be a little bit problematic, but when it comes for education of their own well-being, it comes from a good place. And I think it leads to a wonderful conversation about that and about clinical trials. And so, there's a lot of nuance with that, knowing what is standard, knowing what treatment is there. But that's what we're here for. We're here, to listen to their patients, listen to their concerns, talk about clinical trials, which ones are good, for them, which ones might not be good for them, and to be able to help them, through this cancer journey.
Absolutely. We so appreciate you coming into the studio today to talk about clinical trials. Thanks so much.
I love the show. You're doing an outstanding job, and I'm so proud of you and the work you're doing. I enjoyed listening to this, and thanks everyone out there.
Thank you.
Thanks, everyone, for listening to The Cancering Show with JYP, Dr. Jennifer Young-Pierce. Please subscribe, rate, and review this show on iTunes and anywhere else you listen to your favorite podcasts. Want us to deliver The Cancering Show to your email inbox? Contact us at cancering.com, and we can make sure you never miss an episode. We would love to know what you think about the show, or if you have any suggestions on topics you would like to hear. You can reach out to us on Facebook, Twitter, and cancering.com. Until next time, be healthy, happy, and always thriving.
This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond, with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.